Thank you very much, Oriane, and thank you for to SRUK to invite to share our research. It's been a long day, but also very exciting. I'll try to keep the excitement up and not to be too long, try to catch up with a bit of delay that we have, and share with you what I think it's changing the landscape for how we diagnose and we manage both Raynaud and scleroderma. First of all, for the one who never heard or a bit confused of the word biomarkers, every measure of a biological event can be a biomarker. So blood tests, all the blood tests that you ever done are all biomarker of some process, and imaging test, an X-ray, some feature in the X-ray can be a biomarker. So everything that a doctor can measure of a biological process is a biomarker, and that's what have changed the landscape in medicine over the years, and that's what it's hopefully will change it also for the better in Raynaud and scleroderma. So as a brief overview, we're going to talk about what is precision medicine and in Raynaud and scleroderma. What is in scleroderma and Raynaud that we need to measure to learn about progression, to learn about predicting progression or severity, or to predict response to therapy? What are the biomarkers that we and the NHS have been banking on for the next 5 years? And then the study that is funded by the NIHR, and is a UK study that aims to bring a set of these biomarkers towards adoption. So you heard the word orphan disease and orphan test. So there are some markers that have been adopted by the NHS. They're not orphan anymore, but to become a blood test that your GP or your hematology can ask, there is a lot of research that needs to be done. First of all, so precision medicine. We have, it's a word that you might have read on the newspaper and heard on the news a lot, and it's growing in importance. The more we learn about any condition, the more we realize that under that name, there are many individuals, they are different. And so as soon as, right after we give a tag, a diagnosis, all people affected by Raynaud or by scleroderma, we learn that they're not all the same, and you know better than anybody, and that it is a limit to group everybody under the same name and give the same treatment or the same also diagnostic to everybody. So if we see a group of patients, this can be Raynaud's, can be a group of people with scleroderma, and they all have the same diagnosis, but if it was Raynaud, some will just have a very benign course of the Raynaud, will tend to fade off and disappear over time. Some others will stay stable but manageable, and some others will progress and will become more and more of a burden. In some others, the first symptom of a connective tissue disease, and that will develop in scleroderma one day, in lupus, or in other conditions. When we call it Raynaud, most of the times we don't know who is the red one, the yellow one, or the green one, and the research in biomarkers is sort of shedding light, is assigning these colors. Now, the first study we tried to make the NHS adopt was exactly on Raynaud, and for the very scanty research on what is the natural history of Raynaud, we know that if there is some autoantibodies, the ANA, we call that Raynaud secondary, and that is associated with an increased risk of having scleroderma or connective tissue disease. Now, even that risk is increased, has been measured as only 10–15%. That means that if we, besides the cost, how much is costing to the NHS to screen for all the tests that you do every year, if we want to screen all the patients in 1 year with Raynaud, it will be £187 million of tests not needed. And this is a big problem from the NHS. So they said, okay, we cannot promote a study like that because you need to gain more insight into stratifying these red patients, the one that have an increased risk of Raynaud's if it's only 12%. And this is the research in biomarkers. If we look at scleroderma, it's exactly the same. If today Mrs. Jones come to the office and we to tell her you have scleroderma, you might ask this question, my colleagues have heard this question, what does it mean for my future health? And the answer that you heard is, well, it depends. right? It depends. There are some patients that do very well. In some other cases, they might have some complication. I will not be able to tell Mrs. Jones, this is your case for sure. Most we can do, thanks to the study everybody else has done, is that we can give some percentage and some numbers. And there was a very useful study published by the Canadian group showing that more or less most of the most severe complications of scleroderma happen between 10 and 15% of the cases. And this is true for the severe digital ulcers, it is true for pulmonary artery hypertension, for severe skin fibrosis, for severe lung. But my answer to Mrs. Jones is, I don't know which one you will be. And research in biomarkers, it's for this purpose, to be able to predict whether Mrs. Jones will be in that 15% or not. And this is not trivial, not only for the NHS, we will be able to focus diagnostic on patient have increased risk, but also when we want to test a new therapy, see the bone marrow transplant, how effective it can be, but if we be able to predict the patients that do very badly, then we can focus that very hard treatment only on the right people. So this is the need. So this is the need. It's true for scleroderma, it's true for Raynaud, it's true for the majority of the condition these days. But in case of Raynaud and scleroderma, what we need to measure? So to know, to shape the research in biomarkers, you need to know which are the biological processes that you want to measure that might be significant for the progression of Raynaud and scleroderma. And in the case of scleroderma, there are three main biological processes we need to measure. One is the autoimmune activation. You heard the importance of the immune system from Chris Denton, from Alan Tyndall. What are these cells doing? Well, there is this strong drive of autoimmunity, and you heard from Chris that increase of one peculiar cytokine called IL-6, when we look back at patients, is associated with worse prognosis. Still, we don't know how to use that information when we look forward, so how predictive it is, but we are gaining more and more insight on specific part of the immune system we can measure to guess, to estimate rather than guess what is the progression. But today I will talk more of some specific measures that apply particularly to Raynaud and scleroderma that have been adopted by the NHS for this study to bring this test and become a routine test available. So first of all is tissue fibrosis. So you all know that in scleroderma there is this scarring, this tissue fibrosis. This is quite peculiar of scleroderma and some other conditions, and is specific compared to lupus or compared to rheumatoid arthritis. So it's a very informative biological process to look at to find a biomarker. And then there is, the key cell in this case is a fibroblast, a tissue fibroblast. They produce this scar, this collagen. Now, this is particularly important because despite what happens in other inflammatory conditions, when you shut off the inflammation and the effects of the inflammation, the pain, or the swelling, they go right away. In case of scarring, that scar stays for a long time, sometimes forever, sometimes it gets reabsorbed a bit, but it takes a very long time. So preventing that to happen is crucial. And the processes to measure this scarring is one of the biomarkers we are studying. And then there are these other two very important and peculiar phenomena in scleroderma, which are this vasculopathy, with the reduced capillary density, and the neointima proliferation. These are hard names. I will try to make them simple. Basically, there are two main issues with the circulation. One is the very little vessels, the capillaries, that here in a normal skin biopsy are in brown, okay? In a scleroderma skin biopsy, still brown. You see they're less. They're less numerous. The density is less. So there is less of this little vessel per square inch of skin or per square millimeter of skin. And this is cause of all the symptoms that you all know. Together with the scarring, and together with this neointima proliferation, this is a phenomenon of the big vessels, where instead of being nice and big, like you see this artery, they become narrower because of this proliferation of these peculiar cells inside. And the narrowing of these vessels is the cause of pulmonary arterial hypertension, as Chris mentioned before, of severe Raynaud, of renal crisis, of the ischemic symptoms of the gut. So this is a crucial biological process that is worth to measure in scleroderma. As it happens, the Raynaud's is more severe in patients with scleroderma because of this phenomenon, because the vessels that are not just contracting more to the cold, but they start from a reduced amount of blood they can carry. So if they can already carry less blood before contracting, when they contract, the symptoms are a lot worse. So these are the three main biological processes we focused in the past 6-7 years to identify biomarkers that can change the management of scleroderma. To make things a bit more complicated, we know that in scleroderma, this fibrotic process is systemic. We see it in the skin, but when we see it in the skin, in many cases it's already happening in the gut, but we don't realize it yet. It's happening already a bit in the lung. So when you want to measure, you exactly don't know where is it coming from. Is it coming all from the skin, from the muscles, from the lungs? And the target organs, so the lungs, the skin, the gut, are affected by both processes, by the fibrosis and the vasculopathy. So measuring one does not reflect all the things that are going wrong in the skin or in the gut or in the lungs. And each organ has a different capacity of functioning, even with less functioning cells. So we realize that the kidneys are not working properly when there is already 70% of the kidneys not working. Until then, all the tests that we have, they don't show any sign of kidney failure. And this is true for the kidneys. For the lungs, it's a bit less. For the gut, it's even worse. We were talking with a colleague gastroenterologist when we realize about the symptoms. There is a large part of the gut that is already affected. And the third thing to take in consideration is that the different organ manifestation, they come at different time. So while if this is the skin progressing, we know that the lungs are coming, the lung problems sometimes are coming later on, while the heart may come a bit early, can present somehow in between, whereas the gastrointestinal involvement, the gut involvement, it's present since the very beginning, although it can become a burden only later on. Now, taking all this in consideration, we have been prioritizing among all the biomarkers known a series of tests that we think it can be very informative. Now, the problem is that doctors can get a bit overexcited about biomarkers sometimes, and they can start to talk a weird language. So biomarkers help us to measure what we want to measure, but they are not the condition, and so they are not the problem. We need to be careful, and I will try to be as practical as possible, not to talk a bit of nonsense. So you've been affected by increased TGF-beta. It's something that is true in a sense, but it does not translate properly into what we really want to address. Now, I will not give you the names of these molecules. They are publicly available, and actually they're even here written for the closer ones. But in a nutshell, what we have discovered 3 or 4 years ago, that some of these molecules that are produced by fibroblasts together with the collagen, with the scar tissue, can be measured in the blood, and they correlate, means that they go higher when the skin score goes high. So patients that have a severe skin, they have higher concentration of these markers. Patients that have scar in their lungs, they have higher values of this test compared to patients that don't. And there is also correlation with the severity of the gastrointestinal involvement, of the muscle involvement, and all. So this is called proof of concept study, when you study a group of patients with different severities and see whether these tests somehow correlate. It's very comforting to see that they do, but it's only the first step. You need to know if this is predictive of progression, or just going up because the skin is up and I don't need a test because I can see that the skin is fibrotic, and that warrants for future research. At the same time, many groups through the world, they publish the value of a fourth biomarker of this vasculopathy So a biomarker that is called NT-proBNP that has been shown to correlate with the severity of pulmonary arterial hypertension, with the severity of cardiac involvement in scleroderma, and not only scleroderma. So we wrote to the NIHR, which is this research part of the NHS, and asked to adopt these biomarkers for further development. That means this is the proof of concept. This is how valid they promise to be. We want to do the research to bring them to a test that can be run by everybody. And the first step they asked us to do was to check now in a retrospective course, so in an historical cohort of patients, whether this could change over time. So show me that before you tested in a prospective study, patients that actually progress in their lung have this test that is going up or down. And that's what we did. Funded by the MRC, we could collect sera from 6 centers in Europe, belonging to 5 different groups of patients. One is patient that had progression of at least 5 points of the skin predictive of progression. So this could benefit to know whether that Raynaud will stay Raynaud, will become scleroderma. Patient that had scleroderma for a long time will benefit to know whether they are not, they will not develop pulmonary arterial hypertension for the next 12 months, and so on. Now this is part of the study that is funded by the NIHR. What is it? It's called prospective study. So once we have these 4 tests, now we want to test them in a real life scenario in what we call observational study. So we will not change what we usually do, and we see patients every 6 months like we do in Leeds. And after 4 years, we expect some patients to develop severe lung fibrosis, some patients not, pulmonary arterial hypertension or not, and so on. And at the end of the 4 years, we go back and test how predictive were these tests of what happened later on. What you see here that besides these biomarkers, we will also test 2 imaging biomarkers that we have developed in Leeds, and I will spend the next 10 minutes to talk about it. Together with the blood test, we mentioned at the beginning, every measure of a biological process called a biomarker. So imaging, they are a very powerful source of biomarkers. And we set up in Leeds a few years ago this optical coherence tomography, which is very similar to an ultrasound. The Leeds patient that I recognize here might know, they know it, they can confirm. It's very benign, it's not painful. It's just a probe that is put on the skin. And we set it up at the beginning to have an accurate measure of how fibrotic is the skin. You know that we measure it with the skin score, which is valid, but it can do with some improvements. And after only 30 seconds of scanning, you have a virtual biopsy where you can see the architecture of the skin. You see this is the skin surface, the epidermis. You see here the dermis with all the vessels of a healthy skin. And this is the image that you see when you scan an area that is severely affected by scleroderma. So you see how compact it is. You see that the skin is stretched and there's a lack of vessels. So with these images, we went to the computer guys and said, okay, now find a measure that will tell me, give you a measure of how fibrotic this is, how scarred this is, and also a volume of these capillaries so that we can track that over time, and we can use it to see whether therapy is effective or whether these are worsening and the patient is progressing and so on. And that's what we did. So the first part was the fibrotic part, and we found that these 2 measures that we called minimum and maximum OD, which is optical density, correlate with the skin score. So they had this proof of concept validity. And most importantly, they were extremely reproducible. If 2 doctors were scanning the same patient at 1 week apart, they could find exactly the same value. So it was doctor independent. And that means that could facilitate enormously multi-center studies or also clinical management. And then we learned that perhaps within these measures, we could also find some predictors of how the skin is progressing. And this is what the current study is evaluating. And the second task was, okay, try to measure these capillaries here. And this, at this point, the software people helped us a lot. And they, how do I start this video here? If you click on the video, please. So, yeah. You can see you can extract the vessels from a healthy skin, and you can see all the capillary network which is behind the skin surface, how well represented they are here. And this is the skin affected by scleroderma. You can clearly see that they are so little, and this is without having a skin biopsy. So in this case, we can see it as well, but we have to take the skin out and do immunohistochemistry. We can see it in a non-invasive way in all the areas of the body as many times as we want. And besides this visual image, what's most important, we have a number. We can say that the total volume of the capillaries per skin is X, and we can check how that goes over time. The last biological process we wanted to measure and test is this one. It's this neointimate proliferation. I mentioned at the beginning how important and how peculiar of scleroderma is this phenomenon. If we identify a biomarker of these vessels becoming narrower, we'll be able to predict the future severity of Raynaud. We're able to predict if a therapy is effective. And that's what MRI helped us. So we tried few tests, and the most effective what is no contrast MRI. You know, the MRI is already safe compared to X-rays and TCs because it does not give any radiation. But the contrast sometimes can be tricky. So we set up, in collaboration with the radiologist, a no contrast MRI. This is a 3-minute scan. In this case, it's my hand. You can see how easily you can see and reproduce the entire hand. And with this technique called time of flight, without any contrast, you can see the arteries that are flowing through my fingers. So according to this technique, this artery is only the inner volume of the artery. So it's actually the empty part where the blood flows. And it was very promising, and we asked one of our most affectionate patients, that is always keen to volunteer first, to check how this MRI would show her hand. And this is Kate. She had an amputation on the second finger because of a gangrene a few years ago, and she has a digital ulcers on the third finger here, while the fourth and fifth finger are somehow better. And this is her MRI of her arteries. You can see that these arteries are thinner indeed, and they are so thin on the second finger you cannot see them. On the third finger you can barely see them. You see a bit better on the fourth, and so on. So this is called proof of concept. We know that this actually is a good technique to visualize the arteries. And what is most important also in this case is that you can measure the volume, and this volume in this case is here, is in cubic centimeters, you see, will reflect the inner layer of the volume, and we're testing whether this is a good marker for risk of progression of Raynaud into scleroderma and scleroderma into severe digital ulcers before the digital ulcers happen. At that point, we could also have to consider that not all hands are made equal. Some people have big hands, some people have small hands. So we invented this, what is called Davix, which is the ratio between the arteries and the fingers. It basically just to take into account how big are the fingers that we are measuring. And this is the proof of concept. Patient with scleroderma and severe hand vasculopathy had very low score compared to the healthy controls, and this is finger by finger, and that's why this was adopted for further testing. What is this further testing? This study is sponsored by the research part of the NHS, the NIHR, and that means it has embedded all the boxes they need for a blood test to become available. So the health economic test, how stable is over time, can this blood tube travel on an ambulance for 3 hours until the lab and give you still the same value. There is a lot of research behind the scenes in any new blood test before the NHS says, yes, I like it. And so far, it's planned to be studied on 800 patients in UK, 400 with scleroderma and 400 with Raynaud and specific scleroderma antibodies. And it started in December. So far, we recruited almost 179 patients in 5 or 6 centers, and the study is going. So what we aim to see? We aim to see in 4 years how many of these tests are actually effective in predicting progression, and how we can combine the information of these tests into one score that will give us a risk for progression or not. And that is the ultimate aim. So for precision medicine, we want to ask to some other biomarkers, together with the one that we take in clinic every day, additional information to be able to predict better than we do today what's happening for Raynaud and scleroderma. And so I'll be able to say to Mrs. John, your test, your sclero score, as they decided to call it in University of Leeds, it's high. We'd rather give you a strong treatment now, even if your skin doesn't look too bad at the moment. Or the contrary is pretty low. I'm confident that this is not going to happen. This is what we're trying to do, and we will know in 2.5 years or 3. Thank you, and I hope that I squeezed it enough, and I'll take your questions.